I will discuss with you about idiopathic left ventricular hypertrophy in the setting of sudden cardiac death. So, first of all, I would like to try to answer a question. So, what is left ventricular hypertrophy? And generally, as cardiologists, we have a dichotomous approach to answer to this question. So we classify as bad left ventricular hypertrophy or good left ventricular hypertrophy. We generally consider that left ventricular hypertrophy is a final common pathway of various conditions, like, for example, hypertension or cardiomyopathies, valvular heart disease, or coronary artery disease. And then, of course, on the other side of the spectrum, we have a good left ventricular hypertrophy, which often relates to athlete's heart and physiological cardiac adaptation to exercise. And then we learned that there is not one type of left ventricular hypertrophy, but there are different types. We may have eccentric hypertrophy with increased LV size. We may have concentric hypertrophy and remodeling with the increase in left ventricular wall thickness. And of course, when we talk about left ventricular hypertrophy, in this setting, in the setting of sports cardiology, we are very concerned to miss something like hypertrophy cardiomyopathy, which is a known cause of sudden death in young individuals and in athletes. And generally, when we talk about hypertrophic cardiomyopathy, we think about investigations like ECG, echocardiogram, cardiac MRI from the world of the living, but we have to remember that the first description of hypertrophic cardiomyopathy in the modern era comes from autopsies, from Postmortem. So this was the work from Donald Tier from St. George's Hospital more than 60 years ago, who described 8 cases of what he called muscular hamartoma, 8 cases of young individuals that died suddenly. He described the most typical histological feature of hypertrophic cardiomyopathy, which is myocyte disarray. And he even, in some way, described the familial nature of the disease. So, what is idiopathic LVH? It is defined as a heavy heart, so more than 500 grams in males and more than 400 grams in females. In the presence of myocyte hypertrophy, with or without fibrosis, in the absence of significant myocyte disarray, and of course, left ventricular hypertrophy is unexplained. It's mainly an autopsy nomenclature in the setting of sudden cardiac death. So how do we say that more than 500 grams in males and more than 400 grams in females is abnormal? Well, generally, we refer to this seminal study from Kitzman et al. From the Mayo Clinic, published 30 years ago, which described more than 700 specimens of individuals who died without having any cardiac disease. And Kitzman described the normal heart weight in males and females, and described also some nomograms according to the body weight. And we see that generally in females, the threshold is 400 grams, and in males is 500 grams. And idiopathic LVH and idiopathic fibrosis, so findings of uncertain significance, has been described in the setting of sudden cardiac death. This is a study from our group, and we showed that 16% of athletes that die suddenly had post-mortem finding of idiopathic LVH, 8%, and idiopathic fibrosis, 8%. So it's quite relevant. It's more relevant than hypertrophic cardiomyopathy in this cohort. What is the prevalence? We have different studies, different cohort, and we have a prevalence of idiopathic LVH in the setting of sudden death in athletes and non-athletes, which ranges from 3% to 30%. And I think that one of the main questions is what is the significance of idiopathic LVH in the setting of sudden cardiac death? Is it hypertrophic cardiomyopathy or not? So there are various theories that answer to this main question. One is that idiopathic LVH may be a pathological variant of physiological LVH in athletes who are genetically predisposed. Another theory that is part of the HCM spectrum, or a trigger for fatal arrhythmias in individuals with an underlying arrhythmogenic syndrome, or an innocent bystander. And we don't really have an answer to this question, but we'll see in the next slides that we tried in some way to answer at least partly, to this question. So, of course, dealing with the first slide, we have good left ventricular hypertrophy, the athlete's heart, physiological cardiac adaptation to exercise. And we know, we've been knowing this for a few decades, that athlete's heart means electrical, functional, and structural changes. And of course, related to LVH, we know that athletes may have LVH and may have increase in LV mass. So another relevant question is, athletes have big hearts, so can idiopathic LVH be in the spectrum of cardiac adaptation to exercise? However, a question that is related to that is, what is the normal heart rate of an athlete at postmortem examination? An athlete that doesn't have a cardiac disease and that doesn't die suddenly. And so far, we don't have an answer to this question. There are no cohorts that describe the heart rate, the normal heart rate of athletes at postmortem examination. However, we can consider that the heart rate at the postmortem is given by 2/3 by the LV mass, including, of course, the interventricular septum. And this relates to data, to studies that were published more than 40 years ago. And even, of course, the description of LV mass at echocardiography at the end of the 70s used echocardiography versus autopsy in healthy individuals. So what we tried to do was to try to describe the degree of increase in LV mass in a population of more than 1,000 elite athletes. These were really highly trained athletes, more than 20 hours of exercise per week. And of course, we expected an increase in LV mass with respect to a non-athletic population. However, we see that just 4 athletes in our population, and there were 4 male athletes, exhibited a heart rate that was more than 300 grams. This was at echocardiography. So we can reasonably postulate, keeping in mind that the heart rate is given by 2/3 by the LV mass, that the definition of idiopathic LVH, more than 500 grams in an adult male and more than 400 grams in an adult female, is unlikely to be in the spectrum of normality. Another important question is related to the family nature of the disease. And of course, when there is a sudden death in a young individual, we have to consider that we always have a family with many questions. What caused sudden death in my father, my son, my brother? And of course, we have to try to answer to this question. We have to find the cause. So we have to trust in some way our expert cardiac pathologist. But of course, this have implications for the family screening that we would offer to the family. So what we tried to do with this study was to try to investigate a series of families where there was a sudden death with idiopathic LVH defined as before. So we gathered data from 46 probants with this diagnosis, or with this postmortem finding. The mean age was 33 years, male gender prevalent, competitive athletes in 30% of the cases, heart weight 544, the average heart weight, left ventricular fibrosis in 30%. And we prospectively screened the first-degree family members, and we screened them extensively with ECG, echocardiogram, 24-hour tape, exercise test, CMR, and Ashmelin test. And the main hypothesis was that idiopathic LVH is part of the spectrum of hypertrophic cardiomyopathy. And these are the results. So is there hypertrophic cardiomyopathy in the families that we screen? The answer is no. So no families were diagnosed with hypertrophic cardiomyopathy in our cohort. However, we had some diagnosis of inherited heart disease, specifically channelopathies. So we had a diagnosis of Brugada syndrome in 22% of the families, and long QT syndrome in 4% of the families. We try to find also some more information from molecular autopsy, which is increasingly used in the setting of sudden cardiac death. And we had information, data on 14 individuals who died suddenly with a postmortem finding of idiopathic LVH. And what we found was VUS, so variants of uncertain significance in 11 cases, and pathogenic mutation in 3 cases. However, we could not find any pathogenic mutation related to sarcomeric genes, possibly related to hypertrophic cardiomyopathy. But what we found was a gene mutation in the LonQT genes, LonQT2 and LonQT1, and 1 case with a LAMP2 gene mutation related to Danon disease. And there was co-segregation with the family members, the screened family members, in the cases diagnosed with the LonQT gene mutation. So, going back to the main question, what is idiopathic LVH? Maybe we cannot answer completely to this question, but what we can say is that probably idiopathic LVH is not part of the HCM spectrum. Why? Because we could not find anyone, any family, diagnosed with hypertrophic cardiomyopathy. And given the inherited nature of HCM, this would make us say that it's unlikely that 2 entities are within the same spectrum. Of course, we have many questions about what is idiopathic LVH. It is possible that idiopathic LVH, as the title suggests, is cardiac adaptation gone wrong. So it's possible that in athletes we have a relationship between exercise and LV mass, that at some point we observe a plateau. But it's possible that maybe in some athletes genetically predisposed, we don't observe a plateau. We see idiopathic. We see a left ventricular hypertrophy that goes to an extent that is in the spectrum of pathology, creating the substrate for arrhythmias and sudden death. Another possibility is that left ventricular hypertrophy is a second hit in individuals that are genetically predisposed because, for example, have Brugada syndrome or long QT syndrome. And of course, this creates the propensity for arrhythmias and sudden death. So to conclude, idiopathic LVH is a possible finding at the postmortem of sudden death victims. It is defined by a heavy heart, more than 500 grams in males and more than 400 grams in females, wall thickness more than 15 millimeters in the absence of secondary causes and myocyte disarray. We could not find any family screened with a very extensive protocol diagnosed with hypertrophic cardiomyopathy after there was a family member that died suddenly with idiopathic LVH. And as HCM is a familial disease characterized by an autosomal dominant pattern of inheritance, it's unlikely that idiopathic LVH and HCM are within the same clinical spectrum. Thanks for your attention.